A quick note about today's episode. John is an operations leader in healthcare. He is not a clinician, he's not a doctor, not a nurse, and I invited him on this podcast for that very reason. There are some things that he says about healthcare and some of the ideas on how to change it, the role of government, some other items that I may not agree with 100%. And I'm keeping this episode in the library. I'm excited to share it because I think we agree on more things than we disagree. And I also think it's important to show diversity of thought on this podcast. The things we agreed about are really important topics about teamwork and culture, and honestly, keeping as much local control as possible. As we all know, our healthcare system's the best. So we really do agree a lot during this episode, but I want to put that caveat. If there's a few things that he says that maybe you're like, I'm not sure about that, that's okay. And that's the same on every episode that we record. I also want to share that as John discusses later in the episode, he does have a neuromuscular condition and used a CPAP device during the episode to assist his breathing. I'm really glad he used it as it's important for his health and for his comfort. But you may hear some pauses and you may hear some extra sounds at various points. And I just want to give you a heads up in case you're not watching on YouTube. Yes, we are on YouTube and you're listening. So the audio quality might be a little bit different. Also, I'm adjusting to a new home office. And so as always, I'm not a professional sound person. So if you have some feedback for me about the sound, about what we're talking about on the podcast, I would love for you to reach out. I would love to hear more from all of you, my listeners. So shoot me a text or WhatsApp or LinkedIn message, Instagram, or email me. On social media, you can find me at Andrea Austin MD. That's my handle for Instagram and LinkedIn. And my email is andrea@andreaaustinmd.com. So I would love to hear what you're thinking, what you want to hear more of, less of, anything you want to chat with me about. I'm really thankful you're here, and I hope you enjoy today's episode. I am really excited today to bring you John Alessandro with me. He has a really interesting background in a profession that we don't always highlight here. We have a lot of frontline clinicians, doctors, nurses, but I thought it was really important to have John here today to share about his background in healthcare operations. So he's going to talk about where plans break down, why accountability disappears, and what frontline teams actually experience. So he thinks deeply about the gap between how organizations believe work happens and how it actually happens. That's what really hooked me about having this conversation. So we'll talk about leadership versus management. This is one of my favorite concepts. So I'm happy to talk about that. Decision making under uncertainty. That's every day, right? And it's getting harder and harder right now in healthcare. And why technology adoption succeeds or fails. And this is such an important conversation with AI entering the conversation more and more every day. So while his experience comes from healthcare, his insights really apply anywhere that you find leaders and problems, which, boy, if that's a statement of the world right now. So John, welcome to the show.
Thanks very much for having me.
So when some of our listeners hear operations, they are probably thinking that you're one of the suits, you're one of the business people that maybe are the problem in healthcare, that are the ones making the doctors and the nurses so mad. Can you help expand our thoughts on that? Tell us a little bit about you and why you're in healthcare.
Well, I'm in healthcare simply because not only am I a student of the game, but I'm also a user of the service. I've been my whole life, including the 4 daughters that I've had. I think that what pulled me into it was about 20 years ago. Best man, who's a double certified ER doc, and I don't mind saying that as an engineer, I carried him through calculus and physics. He knows it's true. But the bottom line is that hospitals are a human logistics system that is so complex, people underappreciate what is really happening at the front lines. It's quite an interesting thing to contrast the manufacturing world, which I grew up in the automotive business first, doing just-in-time manufacturing back in the early 80s, or late 80s, early 90s. But, you know, factories are complicated. Building a car is very complicated, but it's deterministic. You can map it out, you can model it, you can quantify things, you can build inventories when you need it, and store up work if you really think about what inventory is. But in a hospital, they're a complex system. They're like
Yeah.
raising a child. You don't know what you're going to get. The system talks back to you. The patient denies the care. The family gets in the way. The insurance company gets in the way. When you onboard nurses and doctors, they often talk about things that could get them sued. So think of the difference between that day and the day as a plant manager at Ford Transmission and Chassis kind of thing. It's just a totally different world, totally different way of operating. And I think it's very underappreciated how the complexity drives decision making, that drives spending, that creates the burnout and the other things that we are constantly complaining about. 20 years later, the burnout is still the same. Pre-COVID, the burnout is worse. It's just different, and it's fun in some respects to be able to make a difference when people see what can be happen by just changing the context of things rather than the process.
So tell me more. What is your day to day? What do you do in hospitals? So, operations, I mean, it's a huge term. Specifically, how do you get into the mix?
Usually it happens when something terrible happens. Example would be somebody dies in restraints in the ED, and they want to know why that happened. And how do we make sure it never happens? Of course. But the reality is that I'm really doing the same thing there as anywhere else. There's really three pillars to what we're doing. The first one is, and a lot of people don't understand this, your dashboard, it's too late. Your dashboard is what happened. We want to know what's about to happen. We don't want to forecast. We want to know what's about to happen. A look around the corner that says, we just triaged our fourth person in a row that's short of breath, and there's no beds in ICU. Now, you know that at maybe 2 in the afternoon, but when
Right.
does it get resolved? The second thing is, how do you resolve that look around the corner? Because the problems we're dealing with in hospitals don't start big. They're little problems, but the signals are there. And we either don't have visibility of the signals or we're ignoring them. We're not doing anything about it. Very similar to a car alarm that goes off in the mall at Christmas time. Did you call the cops the last time you heard that? Or did you get upset because some jerk left his car like that? That kind of thing. So, at any rate, you need to know what you're going to do before the horn goes off, before you see that problem. What is the protocol? And then the last but not least, and the reason why this is not the purview of your quality team or your consultant team or anybody like that, it's the cultural thing. If you work in a hospital that is telling you to take action and then punishes you for doing it, in any way, punish it is the vague word, but people are afraid to act and they ignore the signals because it's not politically correct. Doc is a big emitter. Whatever the reason is, it's immaterial, but they ignore it until it blows up. It doesn't always blow up. That's what makes it complex. It doesn't always blow up. Sometimes blows up. And who wants to be on the side of that coin when that happens? So you get into this thing where you need to monitor what's happening in real time. And you need to have information about what's likely to happen rather than what has already happened. Every dashboard I've seen has people looking at what happened last week, last month, yesterday. That triage nurse, to get back to the original story, she knows what's about to happen because if you sit and talk to her, she'll tell you. She'll say, I've been here 30 years. I can tell you who's coming in to go, who's staying, who's leaving. At triage, well, typically you have a 2 to 4 hour head start on what is likely to happen if you just listen to the triage nurse. So rather than a new dashboard, we've done solutions like have the triage nurse text the house supervisor. Triage nurse is buying you 4 hours. So what are you doing with it? If you sat with the triage nurse and said, yeah, listen, if you get 3 in a row of these, tell us. Send us a text and nothing else. Just tell us it's 4 in a row, 5 in a row. There's some number that when it gets that high, you know you got to do something. But if you don't do that, what happens is the doc at dinner gets a call from the CNO who says, hey, listen, doc, we're about to go on diversion. We need to let go patient Jones and patient Smith. Well, that phone call at dinner doesn't go the same way as that phone call at 4 in the afternoon. Just doesn't. And you can have initiative after initiative about early rounds, discharge at 11, discharge lounges, calling the family the night before. But at the end of the day, the reason why that patient is still there is unique to that day. The reason why we need that bed is unique to that day. There's nothing you can do to forecast it. So if you could just get yourself a little ahead of the game, the difference you can make is in the 7 figures.
Wow. So tell me a little bit more about how your team operates. Is it a community hospital or healthcare system reaches out to your company and then you come in and observe their operations and provide recommendations?
Yeah, well, basically, all of our marketing is word of mouth. I don't run Facebook yet. We don't do any of that stuff, although we're hearing we should. But for now, podcasting is like our current marketing plan. But at any rate, they give us a call, and it's basically a couple of days of observation. We break down the unit that's in focus in 3 ways. What do they think they're doing?
Mm.
What's the folklore? What's the word in the break room on how things are going? There's the way the process goes, and then there's the way the data says it goes. And
Yep.
between those 3 things, you're able to very quickly come up with what we call early wins. A few simple things we can do to get the culture behind us. If you could get the frontline people to start thinking, these guys are really helping us, you will own them in terms of what you can do as a leader. I'm not talking about us owning them. As a leader, the problem is with the current process improvement folks is that they tend to focus a lot on doing the project instead of building the culture. So when your win is that the process got done, everybody goes to the pizza party and gets a t-shirt that says we did it. But as soon as they leave, it all falls apart and they become cynical on the next one. But if you could get a third of the people, just a third of the people pulling, wait, this is working, guys, let's try this. And kind of working on how to look around the corner. What should they be doing? And have a culture of action that says there's nothing wrong with helping people out the door when it's time to go. I've had a nurse tell a patient's family that the Marriott across the street is a heck of a lot cheaper than a night here in this unit. So why don't you go get better food? Get out of here. This kind of thing isn't going to happen because you put it in a policy. It's going to happen when the culture says it's okay to keep people moving through the hospital.
So tell me a little bit about your take on leadership versus management. What does that mean to you?
Well, I think that it's a tough one because a lot of people in management would, in any other industry, be called leadership and vice versa. So if you're dealing with a big system, obviously a lot of the big decisions are made literally at the system level and it filters down. It's interesting that organizationally you'll find the chief nursing officer for the system, then a chief nursing officer for the local system, and then a chief nursing officer for the hospital themselves. So
Yeah.
who there is the leader? And I think that a lot of things that happen in hospitals, if I'm as candid as I could be, are kind of handed to them. The government comes by with an initiative, a never event or something like this, or their payer does a prior auth on something, and that becomes a problem for them to solve rather than here's their vision of what their community needs. I get into this all the time with things like best practice. Everybody's looking for best practice, reduced variation. Does anybody really want reduced variation? I hate putting it in this kind of vague response, but as an engineer, I want to give you the number 5.3, but I can't. What I can say is that depending on your level, you'll have a reference model of how you want things going. And the real leaders I have met are the ones who can take the intent or the objective of their leader, of their manager, and bring it down to the floor. Say, how do we make this work? And have them work out how to get it done. Sepsis bundles a good example. How do you get that implemented? The government can say what they want, but at the end of the day, because they're just on the floor, the ones that got to screen the patients and make sure things get ordered. So who makes that happen?
Yeah. Yeah. Sepsis bundles are a great example and one that irritates a lot of emergency doctors,
Yeah.
a prime group of our listeners. I want to pick your brain on the boarding crisis. Have you worked at all on boarding problems? Is that
Oh,
a domain we can talk about?
oh, absolutely. In fact, it depends on what boarding you want to talk about. But yes,
It's a national crisis, right? It's been my entire career in emergency medicine. It's only gotten worse. I have not worked for a healthcare system that has solved this problem. I'm curious. Well, one, do you think it's a solvable problem? And two, what are some of the fixes that you've seen work?
very solvable. And if you talk to enough people, you'll hear eventually everybody admit that it's really a throughput problem. It's not a problem in the ER or a problem in the ICU. It's they can't get people through. That triage nurse example that I used
Mhm.
earlier peeks its head out here as well. But I think that if I looked at the skeleton of what always works, the first thing that always works is making sure we harvest the hospital's knowledge so that everybody could use it. How many people are in triage right now waiting to get back? Forget how many people are boarding. How many people are waiting to get back? Because there's a velocity problem here. And what we're doing, I think, is we are so focused on measuring things that we're not interested as much as we should be on what we're measuring it for. For example, how many people per day leave the ICU? Does anybody know that? How fast do these beds become available? Now you could say, but in the end, there's a velocity. When somebody tells me our length of stay is really good in the ICU, they give me an average. And I say, well, if I got in my car and I drove for 4 hours, how far did I go? And they don't know, right? Because you don't know. That isn't enough. How fast were you going? So if you have an ED that's turning at a velocity that's much higher than the ICU, you have a different problem than if you have an ED turning at the same rate as the ICU. But the PACU is pumping out patients. So people are searching for this answer. But the answer is like raising a child. This is a complex system.
Yeah.
I had a hospital system where we had the North Hospital and the South Hospital. Same problem. The South Hospital had just started, this was a while ago, bariatric surgery. And the bariatric surgery required monitoring in the ICU of these patients who were very heavy and had breathing problems.
Right.
Well, the way they scheduled surgery almost begged for a problem starting on Wednesday, because they'd schedule a whole book of them on Wednesday for the doc. And he'd fill up the ICU, and the ICU would be blocked for 2 days. And then over the weekend, people start leaving, and blah, 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 problem goes away. So the solution there is to really get down at the hospital level and find out what the heck is going on with our velocity. And if I drew a graph, you would see a peak around Tuesday, and then it plummets on Wednesday. If that just flattened out, you would have this problem.
Right.
That's the nature of this. It isn't going to be something that's solved with some person with a best practice. It's going to be solved by understanding that the purpose of the hospital is not to provide great care necessarily. The purpose of the hospital is to get you out of pain and at home as fast as you can. Because you have a community resource that's being shared by everybody. So time in the box is the variable. The speed at which you get in and out, get the care you need, is the key. And if we can schedule, staff, and run the hospital with the velocity being the issue, instead of a length of stay or a cost, comorbidity, HCAP score, blah, 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 blah. You got all these things, and none of them align.
Yeah. Yeah, for sure. So going up to the systems level, there's a lot of different discussions about American healthcare and how our outcomes may not be as good as other countries. If you look at infant mortality or maternal mortality, life expectancy, all these different things. And certainly if you do a poll of Americans asking them what they think about their healthcare, only half characterize it as good. So half the people are saying my healthcare is not good. So as a physician, these things concern me, right? So from your standpoint on the operation side, looking at the big system of American healthcare and being in this space for a long time, what are some big system levers that on a government, on a insurance structure level that we could change and make a difference?
Well, that's a really tough one. The real answer off the cuff here is that we really need to understand that at the end of the day, healthcare is a local thing. There really isn't a best practice that easily translates from one thing to another. So to stereotype the system level, or even what the government's doing, it's really a challenge to find something that works, even if your purview is just the local. But then on top of it, you put in incentives and the payers and you mix it up. Again, if the first thing you have to respect is that a hospital is a complex system that changes based on the environment. and you can't control the environment no matter who you are. So if you accept that, what you have to do is you have to recognize that whenever I see a system do well with something, it's usually because they set a high bar on what outcomes they're looking for. I call it the reference model. That's a term I stole from West Point. But what do you want to have happen? And then let the people that you feel highly enough to hire and let administer narcotics to my mother, let them help figure out how they want it to work for them. And when that happens, people start calling it miraculous.
Yeah.
But when the government comes in, says this is the way it's going to be, those are guys with guns that could arrest you. It's just very difficult to get any kind of real success until you embrace who you're really dealing with and the system you're really dealing with. And that's really my mission, is to more educate than kind of heavy handed.
Yeah. I do think after years of being at different healthcare institutions, I definitely agree with you that there's so much complexity. Every community is different. Their health, what conditions are prevalent, their primary care access, their insurance, how things get paid for, natural disasters, vaccine uptake, all of these things end up impacting what you're going to see in your healthcare system. And having more local control and voice and say, one, they probably will come up with better solutions than somebody far away. Two, it gets at this concept of agency, that when I go to work, I have a voice and what I do matters. I think one of the most dangerous problems in our healthcare system right now is apathy. And I see it a lot.
Can't be just a job.
Yeah.
That's not why you got into healthcare, but that's what we're turning them into. Yeah, I agree. Sorry for interrupting you.
Oh, not at all. Yeah. So I want to spend a moment acknowledging for our listeners, and maybe if you're tuning in on YouTube, you've had a recent experience as a patient. And I've had a much more minor issue. I broke my humerus last summer. Joke is it's not funny breaking your funny bone. And every time I'm a patient, I'm reminded of what Dr. Wendy Dean said in her book, If I Betray These Words, is the reason this work matters, the reason you're listening to this podcast, the reason you're a guest on it is at any point, one of us will become patient. It's not a question of if, it's a question of when. And we want the system to work for us. So, what has your experience been through the patient lens, and any words of wisdom you can get to a largely clinician audience?
I can tell you that I've been diagnosed recently with a very serious neurological problem, which is why I wear this thing on my face. But not everybody in your audience is a football fan, but the Vince Lombardi trophy is what they give at the end of the Super Bowl, right?
Yeah.
He's a very well known coach, and he has some wisdom for us here. The wisdom is this: anybody who understands the game knows that any game can make or break a season, and any play can make or break a game, and any player can make or break a play. So on Lombardi football, every player needs to be played, every play like the season's on the line. And by experience with healthcare, especially having to go into the hospital with a respiratory problem, which is very serious to the patient, even though it might be routine to everybody else in there. The bottom line is everybody has to be playing like the season's on the line.
Yeah.
Okay. It's very difficult to understand that a great experience in the ED, and then to be sent upstairs after waiting for 10 hours at a gurney when they're filling out their HCAPS forms. What do you think they're saying? Well, are they saying what great care I got in the ER? They're saying, I can't believe they're just railing against what didn't happen. My own
Right.
experience, I had wonderful care right up to the point where I needed outpatient. And then it breaks down. I got to get my orders faxed outpatient. And they didn't get the fax. And then I've got to get in the car and go pick them up and go get and go send it to them. But the insurance company doesn't like what they got. Blah, 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 blah. They didn't engineer the process like Vince Lombardi. So my entire experience is defined by the fact that it took me 18 months to get the CPAP machine, but the oxygen concentrator showed up in 2 days.
Wow.
You can explain that to me. I'm in the business. So
Yeah, you weren't naive. Wasn't like you couldn't communicate what you needed. And that's the maddening thing about this is it doesn't matter our credentials, our experience. The system is so broken that you think, I always think about in those moments, if I can't navigate this with all the training and all the experience that I have, what hope does somebody with a very small exposure to this world, very small amount of education? I mean, they're just completely lost,
when we meet people, we put them through little interviews and we ask scripted questions. And
right?
one of them is, if you're at a family outing and your cousin, somebody who's a relative, but you see it twice a year, you didn't go to the hospital, would the family lean on you or would you feel compelled to call in, make sure you understood who was on shift, make sure Dr. Jones is there to receive your family member? Now, what percentage of the people who work at hospitals say, absolutely, I would do that? Would you guess? As an experienced ER doc,
I would say most of us would do that.
what does that say about the confidence of the people who work there?
We don't trust it.
We don't
We don't
trust.
trust it unless we know that there's somebody it's that whole adage of filling in the cracks. Oh, well, I know, especially if I call and say it's my family member, Dr. Jones will make sure nothing falls through the cracks for them.
That's right. But the general public has to just deal with what they get.
Yeah.
And it shows. Can't hide that because just because you've seen it a lot because you work there doesn't mean that it's invisible. That's the reality of today's healthcare. If you're worried about what the government could do, well, why did the government involve? If you're worried about a system, why do we have systems? What's the purpose of them? And when you start to think about how healthcare has been evolving, I've been at it 20 years, but a lot of the problems that we're having now, we were having then. So these things exist as a response to some sort of public outcry. That's why we have Obamacare or the Affordable Care Act. There's a public outcry. So now we have a solution. One size didn't fit all. That's it. That's what happened.
Yeah. It's very hard to challenge a system and it's our life's work. And at the end of the day, it comes back to our patient. And this is a problem we have to solve. Our patients deserve better. So I appreciate you taking some time to sit down with me today and get me thinking about those operations things. And I think that with a few take home points for listeners and other episodes they can go back and listen to is this idea of complexity is really important because a lot of when we look at when an event goes wrong, we look at one step at a time instead of the entire complexity of what was happening. And Dr. Eve Purdy was a prior guest, and we talked about complex systems and how the solutions for simple systems don't work in complex systems. And then also what you're talking about here, this idea of appreciative inquiry, that instead of looking at when things go wrong, When do things go right in a complex system? Because those are the North Stars. Those are where we have to start guiding. Those are best practices because they're solutions that are actually working in the complex environment versus some great idea somebody has 1,000 miles away. So I would encourage listeners to go back and listen to Dr. E. Purdy's episode. And then I also want to point them to where they can follow you. Where are you active on social media, or how can they connect with you or your company?
So the best place to go is to LinkedIn. I find most of the people who want to deal with me are out there. I also have a johnnydelisandro.com site, which I really use. I'm doing some book writing and some speaking engagements as well as these podcasts. You can go out there. It's Johnny Delisandro, all one word.com.
Oh, fantastic. And I agree. LinkedIn's a fantastic place, and I found it to be a positive place in the social media landscape. Any parting words you'd like to leave our audience with today?
I think we covered a lot of things. If there's one takeaway, it's build the culture. Build the culture of Fitz Lombardi. You got to have a good day every day. And whatever it's going to take to have a good day, you want to be able to look around the corner and see it coming or not coming and deal with problems before you have them. Not in real time. Real time is too slow. Prevent them from happening. That should be an easy thing for healthcare, is to understand the power of prevention, right?
Absolutely. Well, I love that. And it certainly is going to give me a lot to think about as I head into shifts later this week. That's why I love having conversations like this that energize me and remind me of why this work matters so much, and that our culture, and I talked to my residents about that this week, our culture is made in small moments. We all think culture is this impossible thing, this tsunami size force, but it's the small actions, it's the small acts of grace and kindness and that courage to speak up. So with that's what I want to leave the audience with today. Keep working towards small shifts, what's in your sphere of influence to transform the culture and where you're at. Keep following your heartline and doing great change making work. So thank you, John, for being a change maker and sharing your story with us today.
Thanks for having me. I really enjoyed it.